sort of a little bit about yourself before we get totally into the main part of the...
Sure.
Do you mind moving this way? I'm going to just try to get the door out completely because it's just one more little thing in there. Sorry. This is looking good now.
Okay.
And we're rolling, so just can you just tell me your name, sort of maybe a little bit about yourself, how you got started in the midwifery?
So I'm Debbie Duran Snell. I've been a practicing midwife since 1979. First got started in midwifery as what I affectionately call as a lay midwife back in the 1970s. Women in our community did not want to be going to the hospital at the time because they were being subjected to routine procedures that just were of the time and not very appealing, to have your baby, to have to be shaved and enemas and preps and IVs and flat on your back. And so it was kind of the start of what was happening for women to start taking control of their own situations and their bodies and their births. And so we were a study group that got together. Most of us were either studying to be nurses or already nurses or some way interested in the birth environment, and started attending the women in our community who wanted to be able to have their babies at home, and just continued to have educational opportunities throughout my lifespan, and been practicing ever since. And now I'm in Canada at Mount Royal University as a practicing midwife here in Calgary, as well as the program coordinator for the Bachelor of Midwifery program here.
Oh, you're good. You can say a lot of things without stuttering. I've got to have something under my arm, though, because I'm going to get just a little box or anything. You can just stay there. How about this? Could I use?
Sure.
Oh, that's a big one.
Yeah.
Oopsie.
That must be week 8.
Big game. Everybody, I've got to get a little more stable because I don't want to be jiggling around. Okay, that's perfect. You're very articulate. This is going to go good. This is going to go well. It helps a lot, believe me. So, tell me, can you tell me what sort of you had to present to become, who you are here, like as a registered midwife in another country?
Yeah. Well, because I've been practicing in the United States for quite a while, and I am a certified nurse midwife in the United States, so had the educational background required to be able to teach in a university setting. But more importantly, I think what was of interest to the people here at Mount Royal, and I think to the midwives of Alberta in particular, was that I was coming into the environment here, having been a midwife who'd practiced in both home, birth center, and hospital-based experiences. So the style of my practice that I've had in the past was very consistent with more of a Canadian model of midwifery. But even though I've been practicing for many, many years and have attended well over 4,000 births, I still had to go through the same process to become registered. So I had to apply, I had to provide my documentation, I had to sit the CMRE exam, which is the Canadian Midwifery Registration Exam, and I had to go through what's called an OSCE exams. So that was to assess my skills. So I found them quite fun to partake, even though it had been many, many years since I had gone through those types of exams before. So no, there was no giving me a break coming in. I had to prove that I could practice within a Canadian context and model upon arrival. Mm-hmm.
So, can you tell me a little bit about the model of care here in Alberta and Canada, and if it's different?
I think Canadian midwifery model is almost, if not the kind of premier of what many of us as midwives hope to be able to practice in. The fact that it is woman-centered. The woman is the one who chooses where she wants to have her baby, where she's most comfortable giving birth. So if for her that's the home, then the midwife goes to the home. If it's in a birthing center, which here in Calgary, and as well as in Edmonton, there's a birth center in each city available for the women in those communities if that's their choice. Or she can have a hospital birth, and we do have privileges at essentially all of the hospitals in the Calgary region. So it allows the woman to have the choice to, again, feel most comfortable in giving birth where she wants to give birth. And so that's probably one of the things that I admire most about how Canadian midwifery is outlined. In addition, it's paid for by the government. To have a midwife is publicly funded, and it's a choice that women can make, so they're not forced to have a provider that isn't philosophically what they want. We provide continuity of care, so we are seeing women from the start of their pregnancy through their pregnancy, attending them at their birth, and also being the care provider for their newborn as well as them through 6 weeks postpartum. So that's a real tenet. And then another one is informed choice. And I think that in other countries in particular, that there may be lip service given to informed consent. It's like, I told you about it, here's the form, read the form, sign it, we're going to go ahead and do what we wanted anyway. But here I find that it's very much honored. If a woman has been provided information, she's made an informed choice, we honor her choice in her own care and in the care of her newborn as well. So I think that that's another big key piece here in Canada that's makes us the envy of a lot of other countries.
That's great. So can you tell me exactly how it works with the obstetricians, the pediatricians, all the other different, what's the kind of collegial relationships that occur, and how does the continuity of care aspect play into that?
We do have by being registered, there are certain criteria that we're required to refer or consult for. So we do have those direct relationships with the obstetricians in the community, and we would refer for antepartum conditions as well as interpartum or postpartum conditions. Pediatricians are also available, and in some contexts, family practice physicians may be appropriate for us to refer to as well, especially if it's outside of midwifery scope for common things that might occur antepartum or in the postpartum period that they can take care of. So I would have to say that because midwifery is still very new in Canada, there's some advantages to that and some disadvantages, and one is still that integration within the interprofessional healthcare system. And so here in Alberta in particular, we're working on continuing to develop those relationships. So we're sitting in on committees with obstetricians and with pediatricians and neonatologists. Here at Mount Royal, our students are taking a course that's called interprofessional course in midwifery, where they spend time learning about the other professions and how we integrate and work together. So our students are placed in labor and delivery units with RNs, because our function when we're in the hospital is that we function both as the nurse and the midwife for our clients. So they need to be knowledgeable of how to fulfill the same responsibilities or similar responsibilities. So they get to spend 4 weeks with a nurse. They also spend 2 weeks in a NICU, and not to learn how to care for the newborns in a NICU, but to understand the systems of what goes on, because no family has the expected outcome of having a baby in the NICU. It's almost always an unexpected outcome. And so how can we as midwives continue to provide that care to our clients and support when the unexpected has happened? So what are the community resources? How are the students able to learn what the routines are in the NICU? So you're better able to provide support when your families have that unexpected outcome. And then their final placement is with an obstetrician. So they spend 4 weeks with an obstetrician learning the role of high-risk obstetrics and what happens when our clients are referred out of our care for high-risk care. What does that mean for them? And again, it allows us to provide that anticipatory guidance to our clients so that if we're better equipped to know. And then what we're finding, though, is that those professionals are finding out a lot about us as well. So we're there to learn about them, but they're learning about us. So it's been a very positive experience so far. Our first group of students have just gone through that rotation, and we found that added benefit of what the other health professionals learned about midwives and midwifery students and what's growing in midwifery here in Alberta.
Can you speak to the people who maybe don't really understand the safety and efficacy of home birth for low-risk women with trained care providers?
Well, Canada has many, many outstanding studies on the safety of home birth that have been used worldwide to show how safe home birth is. And part of why Canada is so successful is because of the integration of the interprofessional relationships and the easy referral system that midwives have. So if I'm in an out-of-hospital birth with a client and there's a reason that we need to transfer in, there's no questions at the door when we come in for transfer. It's a welcome. It's everybody working together. It's integrated, and that makes a big difference. So, and because of registration and regulation around midwifery, those guidelines that we're supposed to follow as to who is low risk, who is a good candidate for out-of-hospital birth are followed. And so therefore the women choosing to give birth outside of the home are good candidates for home birth or out-of-hospital birth. Therefore our transfers are low. When they do occur, they're for reasons that can provide continued care for the woman in a different setting. But our safety records are amazing. So very low risk of needing to be transferred in. Most of those occur to the first-time mom who's got a lot of unexpecteds that she's dealing with that first baby. Also, neonatal statistics are outstanding, and so the one study that I might recommend that people look at is the Jansen et al. Study that came out of British Columbia that compared registered midwives attending women in out-of-hospital birth settings, mostly home, with the same regulated registered midwives caring for women in a hospital, and then another comparison group was physicians who cared for low-risk women in the hospital. And as you might not be too surprised, the best statistics were the midwives who attended the women in out-of-hospital birth. So the lowest rate of maternal morbidity and mortality, as well as neonatal morbidity and mortality. One of the things I like to comment about is the frequently cited reasons about neonates being readmitted into the hospital when they've given birth out of hospital. Almost all of those readmissions have to do with hyperbilirubinemia or being jaundiced. Those babies go in for a short time under the lights and then they're discharged back home with their moms. And so if we look at those statistics when sometimes people want to try to twist them and turn them, it's good to look at them more closely. So.
So what does it look like when a midwife transfers in and she does need the support of the obstetrician? How does that work?
Works real well. You know, here in Calgary, I can address that most clearly. So we call ahead to let them know that a transport is occurring. Most of the transports occur by private car. They don't occur by ambulance because most of the reasons why a transport is needed is not an emergency situation, but a situation where a mom needs to have a little more assistance with her labor continuing, or she needs pain medication, and that's kind of the big reasons why. So those don't warrant a ambulance transfer in. So almost all transfers are done by private car. They're greeted when we arrive. The midwife is still a part of the team. We usually, if a C-section is needed, we still maintain that continuity of care and actually accept the newborn into care at the hospital. So our role is still there. We may be co-managing, we may transfer care, and then the care may be transferred back to us immediately following the birth if all goes well. So it's fairly seamless. Sometimes there can be some question as to which hospital we go to, but that all tends to work out pretty quickly. So very few negatives to say about when, other than, of course, it's an unexpected for the client, but as far as the seamlessness of the interprofessional interactions, they're very positive. Yeah. Mm-hmm.
That's awesome. So what was I going to say? Sorry, I had it now. It's kind of disappeared. 'Cause, 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 ' midwifery. I'll come back to me. So tell me a little bit more about how how you prepare the midwives here and to be competent and capable of doing this. I mean, obviously there's a standard to be held in these studies that they're doing. They're doing them with registered providers. So how does that, how do you prepare and know that they're going to be able to do that?
Well, students here at Mount Royal, it's a very similar program to the other Canadian midwifery education programs. So there's not very many of them. There's only 7 currently in the country. All have a similar framework of how they're done. Most of it's a 4-year baccalaureate degree program. The first couple of years of the program really focus on normal. The students get foundation in general education courses as well as biological sciences courses and social science courses. So the students here take coursework in what we call the Gen Eds. That's a requirement for them for the baccalaureate degree. Then they move into what we call the non-midwifery core courses, which are, of course, are anatomy and physiology, nutrition, and a communications course, a women in health from the women's studies course, a health research course, and then they move into their midwifery courses. And so they start taking them in the first year of the program, but they become more clinically intensive as the program goes on. So the last 2.5 years of their educational program are almost all in clinical placements. So, but our students here continue to have what we call tutorials, which are weekly courses where students lead in case-based learning or problem-based learning. Kind of seminars is a way to put it, but those occur every week. So there's a continuation of tying theory to practice as they are actually in practice learning from registered midwives and other healthcare professionals.
So it sounds like it's a 4-year program with the second 2 years being primarily clinical.
With the tutorials.
With the tutorials to help them with the problem solving and critical thinking.
Yes.
So can you speak a little bit to, there's quite a heightened awareness now about how supporting women of diverse cultures and being able to know how to support them and their families in birth. And you know, there's a discrepancy. Of course, we've seen the studies in the States where so many women of culture or you know, of color, different things are having very poor outcomes. How do you see, you know, this shifting, and what would be sort of the ideal scenario?
Well, there's one program of education in the North, which is exclusive to educating Aboriginal women to be midwives for Aboriginal women. So we need to have more women with diverse cultural backgrounds providing midwifery care in the first place. So one of the things that Mount Royal does is 10% of our admissions are reserved for Aboriginal women to be in the program to help build Aboriginal midwifery here in Alberta. There's only one practicing midwife right now who is on reserve, seeing women and caring for them on reserve, and we need to help to bring midwifery back to Aboriginal women. For the most part, that is a style of midwifery care that's traditional for them, and they want to see more of, and they just are not being given the opportunity to have those options. I think also our students here have one course that is called the Transcultural Placement. It involves about 30 hours before they go into a short-term clinical placement where they are in what we call a clinical bound week of intensive seminars and workshops, and some of the areas that our students get exposure to during those workshops are a Aboriginal midwifery workshop. We have a workshop on religious diversity where we have a panel of people from different religions who come in and talk about their childbearing experiences and how that can relate to midwifery care. We have an LGBTQ panel that comes and meets with our students so that they have a chance to actually just ask questions directly. You know, what is it that I can do that it will make it feel safer for you to seek care? And so these workshops are designed to help our students be better prepared and have some exposure before they go out. And then they're placed in international, geographically remote or local placements of cultural interest. And so we have students that go to the United Kingdom, students in the Bahamas, in Ethiopia. Also, we place students at Fort Capel at All Nations Healing Center there, as well as an Aboriginal placement here in Alberta. If our students stay local, they are in non-midwifery practices, but working with organizations and agencies that, one in particular is Best Beginnings. It's a program here in Calgary for teens who are pregnant, and anyone can refer a client they have who meets the criteria to receive services there. So we have students who are learning about what's available there, what are the community resources, etc. So I think we need to provide exposure, but we also need to make sure that we're not being ethically wrong in going and providing care when we don't know anything about the culture or the practices that are special to the people that we're seeing. So just trying to make that blend.
Do you have a certain amount of your students who are Aboriginal?
Yeah, 10%.
Oh, I'm sorry.
No, that's okay. Yeah.
You did say that. Okay. Oh,
Yeah.
can you just say it one more time
Sure.
so that I get it on
10% of our students are Aboriginal in our program.
That sounds really good. So is there anything that you could say to just like the general population of the world who maybe doesn't understand how this problem does affect women of diverse culture, and the statistics, which aren't, I mean, I know even up north with the Inuit, and I'm good friends with Sharon Fraser, who works with them. I actually used to work with her in BC.
Yeah.
But so how could you speak to just the layperson to create more awareness about culture and diversity and respect and understanding for not just, just every different type of diversity?
Yeah. Well, I think, again, it's providing a focus that's woman-centered, and whatever that center is for her is honoring it, learning about it. I think sometimes we shy away from asking questions, and how are we to learn if we don't ask and engage and try to understand? So, but when women in particular are taken away from their community, which can happen in the north, in areas here, not necessarily where Sharon has practiced, because they've worked really hard to get a birthing center and midwifery-led care there for the Aboriginal women, but many Aboriginal women are asked to leave their communities. It's not unusual in other parts of the country. The same happened when I have worked in Nicaragua. Women there were told that they had to come in from the country to the communities where they stayed for 4 weeks waiting to have their babies, away from their families, away from their support, and sometimes away from their other children, in order to give birth in a hospital or health center. So I think we need to bring more of those experiences and more skilled birth attendants to those areas so women aren't, it's very scary, to have to be forced to leave your community, your home, and go where you don't know people and you don't know who's caring for you. And when women have fear, that's going to add to their overall lack of well-being, that's just, so as health providers, we need to be able to try to listen to women, find out what it is that they want, honor what they want, and here in Canada, more of that is starting to happen. And again, with midwifery-led care of Aboriginal women, the statistics are much improved than when women are asked to leave their communities and give birth. And my understanding is that for a woman to leave her community and not to give birth to her child in the land where she is from means quite a bit to her. So she's giving up a lot, and sometimes is forced. It's not her desire. So we need to provide safe, care for those women and options for them that are in their communities instead of forcing them to leave their communities.
Thank you. That was well said. Are you familiar with Robin Lim, who won the Hero of the Year Award?
Yep. Mm-hmm.
She talks about more midwife to mother care as opposed to. So how do you speak to that, like it from a worldwide perspective?
I think that's traditional of what midwives have done throughout the world. I've been fortunate enough to be able to travel quite a bit as a midwife and see and practice in other parts of the world. And what I know about midwives when I meet them throughout my travels is that midwives are midwives everywhere. You know, we love being with women, we love providing that care, and that midwife to mother care, I feel is the essence of what we do and what we've always done. And now we're being able to use our research skills to be able to document how providing that kind of care is good, safe, sound care for women. So I think just, again, that tradition of us just listening to women, I mean, finding out what it is that they want and working within the systems now, because we've been integrated enough to make those changes happen so that we can provide that care for the woman and not forcing care for her. You know, it's listening to her and providing what she needs and wants. So,
why do you think in places like the United States, midwives are not welcome in the hospital in that respect, that they can continue care, and there isn't quite the support? I mean, I know that socialized medicine might play a role in that. So how does socialized medicine play a role in that, and how do you see, you know, what kind of ideas do you have just off the top of your head for creating more integration in other places where we don't have socialized medicine?
I think the model that's here in Canada is one to strive for. Having been both a direct entry midwife in the United States as well as a certified nurse midwife in the States, I've seen both sides of that coin. And what Canada has done by coming to the table a little bit late, they could see what's worked well and what hasn't worked well. And one of the things that they realized is the model in the United States of midwifery care, which is this dichotomy instead of this, you know, unity, was not what they wanted here. And actually there's some amazing women here in Canada who looked at that from the very beginning and said, we have to come together, whether we're nurses or not, we come together and be known as midwives. And so that credential of being a registered midwife is held dearly here, and it allows, again, for us to be able to provide the care to the woman as to where she wants to give birth. So as a registered midwife, I can attend the woman at home, but I can also attend her in the hospital. It's her choice. And so what's happened in the United States with that dichotomy is we have midwives who can almost only exclusively provide care to women who want an out-of-hospital birth. And then we have midwives who can almost exclusively only care for women if they're going to have a hospital birth. And the credentials are different, and there's confusion as to what each one can do. And I think some of the infighting that occurred, 10, 20 years ago is less so now. And I think that there's a coming together of understanding that we're all midwives. And so my understanding, even though I've been away from the United States now for a little over 4 years, is that there's a growing tendency to try to look to each other and come together in a common and unity as midwives as to how we can provide care for women. And so I think here, if we can have more countries mimic what's happening here in Canada, that would only be of benefit, to women overall. So I'm not met, at the door of the hospital saying I can't come in. I'm met here as, yes, come in. You're her healthcare provider. We're going to keep caring for her. You are part of that. But yet I love also being able to have that beautiful, luscious home birth with a client who has, the successful home birth. And that was something missing from what I could do for many years, practicing in the States. So I think there can be some changes. They just need to, I think, come from the consumer as well as from us. So, but us coming together as midwives can make a big difference.
Wasn't there just a conference recently where the CNMs were there? Were
And
you
for
there?
the first time, Ina May spoke as a keynote speaker at the ACNM. Yeah, which is, for those of us that have been involved in the United States midwifery for a long time, that was a big change, for her to be invited, that was a big deal. But I think more women in the United States are choosing to give birth out of the hospital, and the women who are making those choices are informed women who are aware of the care that they're getting and receiving and making that choice. So things are changing. There's a pendulum swish a little bit, and
Can you say that again?
there's a pendulum switch that I think is starting to occur. I heard you mention that earlier, but that's a phrase I use quite often. So where I think there continues to be a growing number of women who are choosing to give birth out of the hospital, and are doing so safely. So, despite some of the very poorly designed studies that have been recently published out of the United States. So,
can you speak to those just for a second? Just about how these studies can be skewed when they're the people who are kind of interpreting them are biased.
Yeah, probably one of my favorite ways to explain the WAC study that came out probably in 2010, I believe, out of the United States, was looking at the statistic of neonatal mortality and morbidity, and cited it as having a 3 times higher rate if you were to have your baby at home. Maybe the maternal outcomes were better, but if you did so, you were only selfish because you were really suffering your child as a result. And it's interesting, when you look at what was included in their neonatal outcomes, it was less than 5,000 for their N. They eliminated many studies that were well-known studies to show low, and one of the classic ones is the De Jong study out of the Netherlands, which had a very high N, so a large number, half 500,000 women were in that study. Very low neonatal rates, very consistent with the Canadian studies that have been done as well. So when you link all of those studies together, it's a huge N of comparison. And but WACS didn't include any of her numbers, and it had to do with the definition. Had the WACS study authors had asked her to give them data that extended the neonatal outcomes further, she could have provided that for them, and there was no change in the neonatal outcomes that she had listed versus the definition they wanted to use. The statistics were the same, but they chose to exclude her study. Yet they included studies where planned place of birth was not considered. So women who may have had a late miscarriage at home were included in the data, and that's the same with this new study that came out recently in the United States, again citing the higher incidence of 0 APGAR if your baby was born at home. And again, their inclusion included any babies that weighed over 500 grams or over 20 weeks. So it was not women who were planning to have a home birth, and I think that's where we need to really look and base our decision of how significant the study is. A woman who's not planning to give birth at home and hasn't a midwife who's planning to attend her at home and ends up having a precipitous birth or a late miscarriage, and that's included in the data, is not necessarily accurate data for us to be looking at. So you always have to look at them carefully. You have to look at what's included, what's been excluded, and why. And if someone's intent is to scare women into not having their babies at home, and you can report that the incidence of a 0 APGAR is much higher in home births, and it only has to do with where you gave birth, but you don't say that it included all these other factors, then you're misleading.
Sounds kind of reminds me of that Dr. Amy or whatever, who's like online, and she's just, I don't know if you know who she is, but there's been some talk about how she's just been, kind of damaging the...
It's much harder to recover from negative things that people say too. Something like you have to say 10 positive things before one negative is something like that. I'm trying to remember the quote. But, yeah.
So it's definitely, I think the purpose of this is to try to get some positivity out there too. So tell me, what was the model that that Canada was looking at? Were they looking at Denmark, or what did they?
Well, New Zealand would be another country that's very similar. Certainly the Netherlands. I think many European countries. Some European countries still don't have a large out-of-hospital birth rate, but certainly in the Netherlands they do. So I think that those were some of the countries that they were looking at as a comparison, but also looking at what not to do as well when they were looking at regulation and registration. Mm-hmm.
It's like you've almost created your own new utopian world here.
Yeah, we still have things to work on, but yeah, I think that, again, just being woman-centered makes a big difference in how care is looked at here.
Mm-hmm. And just, I have one other question, and then anything that you want to add. What would you say to parents who are kind of looking at all these choices and trying to make a decision of what to do, whether they're anywhere in the world? What would you say to them?
That if you're a low-risk, healthy woman, planning to have her baby, look for a midwife to provide you your care. In whatever context that you can have that, where you are right now. We're working to build more of us in the world, but having midwifery care, we are the experts in low-risk care, where we are the women who can provide the care that a low-risk woman needs, that we're able to listen to her, we're able to sit on our hands and wait. We use technology when needed, but we don't overuse it when it's not. And so I would encourage her to look into her community, see if there are midwives practicing in her community, and then think about what would be the best outcome to begin starting to be a mother. Would that be in the care of a midwife who is going to provide you with a safe, comfortable place to give birth, provide the baby with immediate skin-to-skin contact and delayed cord clamping and all of those things that we know can promote well-being in the mother and the baby. And if you can start your family life out in a positive way, why wouldn't you want to do that?
Actually, I thought of one other thing.
Mm-hmm.
Robin Lim's doing this work all over the world and trying to really educate people.
Mm-hmm.
There's so many other cultures that are not, they don't have access to care,
Mm-hmm.
even hospital care.
Mm-hmm.
What do you think about the work she's doing, and how do you think that can help change and shift
Well, I'll tell you about a project that I'm working on. On Tuesday, I'm leaving for Ethiopia. It'll be my second trip there. We are working with the University of Alberta in a program that was generated from the Ethiopian Government and Midwives Association, the Ethiopian Midwives Association. Ethiopia still has a very high percentage, about 90% of women still give birth in their own communities with traditional birth attendants. They're trying to meet some of the Millennium Development Goals to reduce mortality in maternal and neonatal. They're working hard towards that goal, and one of the ways that they, as a government, decided to improve those outcomes was to educate more midwives. So they've educated a lot of midwives, but in a short period of time. But many of those midwives have graduated from their programs without really having very many skill trainings or assessments, or even have caught babies, sometimes as few as only 1 or 2 in their educational programs. So the women, even though the health centers may be in their communities and staffed by these newly educated midwives, the women of Ethiopia are still not choosing to go to them because they lack confidence and competence. And so our project is to work to help midwives who have been practicing for a while to become teachers of midwifery from a context of how to teach skills. And so we are working on a 5-year project in Ethiopia with helping midwife tutors to gain confidence and competence in teaching of midwifery skills. And then they go out to their communities and hold workshops, and then they come back and tell us how things went and what worked well, what didn't. We're also providing them with equipment to be able to use in teaching. So I'm not sure if you're familiar with a product called Mama Natalie, but so they're each being provided with Mama Natalies and Neo-Natalies to be able to take to their communities and help those new midwives gain their skill and confidence in being able to handle emergencies as well as resuscitation in a low resource setting. So we do teach helping babies breathe, and this was all motivated out of the needs of the Ethiopian Midwives Association and recognizing that this was something that the new midwives needed. So we'll be doing that, and then by the 5th year of the program, we'll be stepping back and still participating, but letting them lead these workshops, because there'll be enough of them that have been teaching now and learned all the pedagogical skills around teaching, as well as updates on midwifery skills. So I'm excited about that, and I think that that's a way, if those young midwives can gain their confidence and competence, that more women may be coming to the health centers and being able to be attended by a skilled birth attendant and midwife. And hopefully that will help that country, Ethiopia, meet the goals, even though it may not be done in the time frame that's been suggested by 2015, but they'll be on their way towards midwives being the primary provider of care for women in the country, and also being able to provide safe and competent care as well. So I think that's very consistent with her work and what she's been doing and preaching throughout the world.
Because you've done this, you may have some understanding of how, there's sort of the good traditions, and then sometimes there's the old wives' tales that get kind of, or traditions that are based on misunderstanding
or many years of it working.
Maybe it works and we think it's not.
Right.
I know. We judge things, don't we? But how can we take sort of the best of the old traditional and blend it with the best of the new and make
well, one of the things I want to see us doing in Ethiopia in particular is to bring the traditional birth attendant into the health centers, and maybe she can provide doula care and support to the family that she knows. Because again, that woman may still be coming to a center that's some distance from her home. So one of the things I'd like to see is the traditional birth attendants coming along and maybe providing more of that doula care and service, so that there's still that connection to their home and their community. So I think that that's one way. Also remembering that, if somebody in a culture has been doing something for hundreds and thousands of years and there's been no negative outcome as a result of that, why would we want to change that? So Ethiopia, they have coffee ceremonies that go on while women are in labor. It's a way for the women of the community to bond together through this life-affirming event that's happening. And so I think we need to look at that. But again, if there's traditional herbs that have been used or such, we don't need to necessarily know from our Western culture what that is. If that's been working in their communities, there's probably a basis for it. And so I think we need to honor what I call that art of midwifery that we hand down from woman to woman and midwife to midwife, but blend it with some of the science part as well. So that's what I hope to be providing to our students here at Mount Royal as well, is that just general acceptance and honoring of the art, but also blending it with the science.
I love that. I have one more question that I had thought of earlier, but when I lived in Airdrie for a year, and I went and visited I believe it was a Hutterite colony, and you were mentioning you had like a panel of people that talked. What are some of the local, aspects of that are specific to understanding different cultures? And
I won't address that community quite, just because they haven't seemed to be very interested in midwifery care. Hutterites have tended to want to have hospital birth and technology, and as a community, they've integrated that some of the technology into their farming, etc. So it fits with their culture. But certainly there are other communities and religious communities that have wanted to embrace. There's several midwives now down in the Cardston area where there's a high percentage of women who are LDS, and those women are just thrilled to be able to have the option for midwifery care again. I think there's also Mennonite communities here in more rural Alberta that also embrace midwifery care and are starting to have more options as we get more midwives into communities. But still, we need more diversification of where midwives are located here in Alberta. We're along I call it the QE2 corridor, between Edmonton and Cardston, and everyone along the line of that highway. And we need to start venturing out a little further. And certainly I know the women in the farther north, Fort McMurray area, etc., are just so wanting a midwife to come there. So we need to be looking to expand where midwives are able to practice, and that's something that will be happening with Alberta Health Services, we hope, in the near future. A task force looking at where workforce planning can be and where midwives can go, and how we can support those midwives who do want to work in those more rural practices as well. So,
That's great. I like that.